Hello, I'm Dr. Greg Silverman, Professor of Medicine and Pathology from the NYU School of Medicine, and I welcome you today to our Rheumatology Highlights Report that's hosted by the Cleveland Clinic R.J. Fasenmyer Center for Clinical Immunology, and our topic today is Systemic Lupus Erythematosus, Pathology, Diagnosis, and Treatment. So our learning objectives will be that as a result of participation, everyone should have a better appreciation of advances in our understanding of the risks for cardiovascular complications in SLE. We'll also discuss recent developments in understanding the mechanism of action of Mycophenolate Mofetil as an immunosuppressive for lupus. And lastly, we're going to describe recent advances in the rationale and improvements in development of agents that target interferons in lupus patients. So here I just want to first review some background literature that better describes the associated risks for premature death in patients with systemic lupus erythematosus. And this paper that was from 2006 actually shows us that in patients that were followed for different 10-year periods, in fact, while overall mortality seems to be improving, the causes of death are somewhat changing. And what we can see in the most recent period, which was 1990 to 2001, that in fact total deaths decrease, and there may be decreased associated infections and renal causes, but in fact cardiovascular or circulatory deaths are not changing over time. So this is quite disconcerting. This data suggested that overall the standardized mortality ratios in lupus patients showed an increased risk of death of 2.4 per time period. And in fact, the greatest risk was for patients in their first year of diagnosis. And somewhat unexpectedly, the highest death rate were associated with individuals that were less than 25 years old. And this may have to do due to disease activity and the severity of initial presentation. And significantly, in this study, they found that overall cardiovascular diseases as a cause of early mortality had an increased relative risk of 1.7. Now, that's relatively modest compared to some of the other studies that have been published, and I'm just going to also touch upon this classic paper from Sumanzi, who looked at patients with lupus, and particularly women with lupus, and looked at the relationship between the incidence of myocardial infarction in female patients at different age groups. And what you can see is that there's really a remarkable increased risk of events, particularly very early on. So lupus patients that are 15 to 24 years of age, they actually have some very substantial incidence rates of myocardial infarctions that are really comparable to those being experienced by patients somewhat of more advanced years. But we can see that as patients get to be 45 to 54 and 55 to 64, that in fact there remains this risk of myocardial infarction in lupus patients, but only at these later ages do we see the general population that women are starting to have myocardial infarction. So the real concept is that the risk of cardiovascular significant events and early mortality is associated with lupus even from early age points. And particularly this is very, very uncommon in women because, in fact, we know from looking at general surveys in the population that myocardial infarctions are distinctly uncommon in premenopausal women, and particularly looking at people as young as 15 to 24 that they're having significant frequencies of myocardial infarction is quite disconcerting. So now shifting to a poster that was presented at the recent ACR meeting, and this was presented from data at the Johns Hopkins Medical Center. There's been an accrual of a cohort that has been followed over now 10 years to look at the relative risk of cardiovascular events. And the goal was really to see whether or not initial features and different risk factors might actually predict for the development of cardiovascular events during that 10-year period. And so there's been an evaluation that included things like the traditional Framingham risk factors as well as other features that are lupus specific. Now this study is ongoing, and the results presented had to do with trying to identify risk factors occurring during the first 2 years of observation. And in this cohort of 1,342 patients who were 93% female, there were a total of 109 cardiovascular events as detailed here. So if we go and look at the table, you can actually see that, in fact, they found that there was an increased risk of cardiovascular events that increased with 5-year durations or 5-year intervals of lupus. They looked to see whether or not there was a difference in whether or not the patient was a male or a female, and in fact, different studies have suggested that men, in particular, that have lupus may have, on average, more severe disease. They found a trend, but it really wasn't significant. There was predicted associations with traditional risk factors like hypertension, as well as cholesterol over 160, smoking as well. They did make significance for diabetes, but really the important thing that I want to draw your attention to is that if we looked at actual lupus disease activity, and there's a score by the SLEDAI scale of 2 or more, so significant disease activity, that in itself actually seemed to be associated with risk of cardiovascular event. And an independent variable was whether or not there was a history at any time of a lupus anticoagulant, and also if there was evidence of a low C3 suggesting that there was active immune complex mediated disease. So the goal of these studies are actually to see whether you can build a composite score and see which individuals are at greatest risk of cardiovascular events. This is just a preliminary study, but it suggests that in the future there may be some opportunities to better identify what subsets of lupus patients are at greatest risks. So I'm going to shift to an abstract that in fact was presented from our research group here at NYU, where we studied levels of the circulating free protein S. And protein S is a vitamin K-dependent factor, which is involved in controlling coagulation, and it's also a ligand for an anti-inflammatory pathway, this TAM receptor kinase family that can regulate inflammatory responses. So it has dual functions, and it's very relevant potentially to the DVTs and pulmonary embolism that can be associated with lupus, because those appear not to just be thrombotic, but potentially can be inflammatory events as well. So we looked at a cross-sectional survey of samples from 90 lupus patients and assessed their levels of free protein S, and I should say that in vivo, the majority of protein S circulates as a complex with C4 binding protein. So this is evaluating specifically the proportion of protein S that's free and available to actually affect thrombosis or have other functions. The result was that we found a very significant association that low protein S levels correlated with a history of DVT or pulmonary embolism, actual events. And in fact, when we compared this to other more standard lab evaluations, including IgG anticardiolipin and IgG anti-beta-2 GP1, and even the Russell Viper venom test, in fact, the correlations between having had an event and having low protein S were actually stronger and appear to have greater sensitivity than other laboratory measures. Interestingly enough, in individuals that had a history of either a myocardial infarction or cerebrovascular events, so these are arterial events as opposed to the other events we were talking about, which were venous, we also found evidence that those individuals had lower levels of free protein S. We tried to look at whether or not there was any evidence that Coumadin intake was influencing the results, and there was no evidence that that was involved. So from these studies, we found preliminary data to suggest that there may be a different pathway responsible for both venous and arterial thrombosis in lupus patients, and that measuring free protein S levels might provide benefits in better segmenting patients. But the question is whether or not this will hold up in prospective studies, which needs to be done in the future. So shifting gears away from vascular disease, I wanted to bring to the attention of the listeners in the audience a recent publication on Mycophenolate Mofetil. So this is an agent that was originally approved for the treatment of transplant rejection, and actually in a head-to-head randomized controlled study was shown to provide benefits in patients with lupus nephritis. So it's really been embraced by our community and is having increasing use. The question is, what is the appropriate patient to use this agent in, and whether or not, in fact, there are interactions with other therapeutic agents that we're using. And I bring this to the attention of everyone listening because there was a report of a controlled trial that unfortunately had to be halted prematurely after just several patients were enrolled. And this was a trial in which MMF was used as a background therapeutic immunosuppressive agent, and this was used in coordination with an experimental biologic agent called atacicept. And atacicept is a fusion protein with a receptor related that binds to BAFF, B-cell activating factor, or the APRIL, which is a proliferative inhibitory ligand. So this actually soaks up these B-cell survival factors, and the question was whether they were going to find efficacy in lupus patients. And unfortunately, they found a really terrible profile of side effects, but only in association with MMF, at least that was the impression. Immunoglobulin levels actually precipitously dropped, and there were actually several patients that had serious infections. So this was somewhat unexpected, that the activity of this biologic agent that was very targeted and should really only have had specific effects on these survival factors, nonetheless had very significant induction of hypogammaglobulinemia. And of course, this is not something seen with other agents that seem to have comparable mechanism of action. Belimumab, which is an antibody just to BAFF, in fact, this is not seen. So there were questions raised, what actually is the mechanism of action of MMF, and might there be overlap with that of atacicept? So in an open-label trial of 107 patients with lupus, they looked at their clinical response to treatment either with MMF or azathioprine, and then they had 38 patients, about a third of the group, that were on no immunosuppressives at all. But these cross-sectional studies after people were on established therapy showed, in fact, that if you were on azathioprine, there were significant blood B-cell abnormalities with shifts in populations that are associated with very active lupus. So this has been reported before, and there are decreases in these patients on azathioprine with regard to lower levels of B-cell precursors, so that there was some problem with trafficking in the bloodstream, and even more significantally, that active lupus has been correlated with high frequencies in the blood of plasmablasts, of Ig secreting cells, and maybe these are cells that are involved in secreting autoantibodies. The important observation here was that when patients were treated with MMF, these abnormalities normalized, and levels of transitional B cells and mature circulating cells actually were normal, as well as there was a normalization of plasmablasts, and so it didn't appear as though the B-cell compartment was activated. They found no abnormalities in T cells or other cells that they examined, and they went on to do some in vitro studies to look at the effects of MMF on B-cell functions, and they found that MMF in vitro could actually block the induction of proliferation of B cells and the activation of B cells. And this appeared to be a very selective function. And the truth is that this is rather unexpected, because mycophenolate mofetil is something that has a general mechanism of action to interfere with nucleoside recycling, so that the effects on cell cycle were previously not thought to be specific for one type of cell or another. And here there's evidence to suggest that they may be more focused on B cell compartment. And this may well explain why the use of two different B-cell specific agents or active agents, the atacicept and MMF together, actually brought out an adverse side effect profile. But this will need to be explored in the future. But it does, in fact, speak to the fact that MMF can be very active and interfere with basic pathways of pathogenesis in lupus. Moving on to our last topic, I just want to remind everyone of the opportunities that are being explored therapeutically for the targeting of type 1 interferons in lupus patients. So many patients with systemic autoimmune diseases, including lupus, appear to have a dysregulated excess production of type 1 interferon, and if you profile the blood cells and look at their transcripts, you can actually see upregulation of interferon alpha regulated genes. So there's a distinct abnormality in the biology of lupus patients. And this can actually result in activation of plasmacytoid dendritic cells, and these appear to be stimulated by immune complexes. And so then there's excessive production of alpha interferon, and there may be major contributors immune abnormalities and disease in general, and this may drive cells in the innate immune system to injure different tissues. So there are variants of genes that have been shown that are involved in alpha interferon synthesis to actually be also linked to risk for the development of lupus and other autoimmune diseases. So it's not just an observation where there is more interferon in the circulation and more interferon-inducible genes, but actually susceptibility development of disease seems to be linked to abnormalities in control of interferon synthesis. And these are genes such as the interferon regulatory factor 5, IRF5, as well as STAT4. And these are all involved in regulating the responses to interferon. Based on biologic evidence that alpha interferons may be dysregulated and contribute to the pathogenesis of lupus, a number of agents are now in clinical development that may well block these pathways. So here we see that a number of different companies have developed different monoclonal antibodies. Examples are AGS-009, Siflimumab, as well as AMG-11, MEDI-545, and Ronilizumab. So most of these are targeting alpha interferon. Actually, the biology is quite complex because there are a number of different isoforms that are involved, and not all of these antibodies necessarily block all of these different isoforms, and it may not be desirable to completely block this pathway because, in fact, alpha interferons are involved in defense from different types of infections, particularly viral infections. And there are different stages of development. But let me just give an update on Ronilizumab, which is, again, an IgG antibody to alpha interferon. And in a recent published report, it was shown that generally there was a dose response. The higher the dose that was given, the greater the levels of the antibody that was obtained in the circulation. And the clearance and terminal half-life were just as seen with many other biologic agents. It was well tolerated in both intravenous and subcutaneous administration. So in general, these preliminary results were very supportive of going forward. And at the recent meeting, results from a phase 2 trial were reported on efficacy and safety in SLE patients. So in this study, 159 lupus patients were entered into a double-blinded phase 2 randomized controlled trial. And in this study design, they actually stopped all other immunosuppressives at the time of randomization, with the goal being to better appreciate the effects of this antibody to alpha interferon. In addition, glucocorticoid doses were tapered such that by week 8, patients could be on no more than prednisone 10 milligrams per day. All the patients at this time point had significant active disease with a mean Selena-SLEDAI disease activity score of 9.8, and most of this was involving the musculoskeletal system or mucocutaneous systems, as is seen in many trials. They try to avoid active renal disease and CNS disease. Unfortunately, this trial did not attain its primary endpoint, and they did not find differences in the overall response rates in those that received treatment with this antibody versus placebo. However, they did find that if they looked at the effect of Ronilizumab infusions on disease flares, there was a significant reduction. So there was a relative hazard ratio of 0.6, so reducing about 40% the number of flares that were seen in the control group. They did further evaluation in an attempt to better understand the potential mechanism of action, and all of the patients were evaluated in vitro so that they looked at whether or not there was an interferon signature that was induced, and it was a quantitative metric, an interferon signature metric that they decided upon, and they divided those patients into whether they were high for the signature or low for the signature. And the hypothesis would be that this somehow might be related to disease activity or what the major pathway of disease was. And what they found was that, in fact, there were significantly better clinical responses based on a SLEDAI scale on lupus patients that were actually signature low. And this was particularly true after IV treatment. And so, at first glance, this agent did not appear to be potent enough to affect disease activity in all lupus patients. And interestingly enough, those that appeared to have better responses actually had lower interferon signatures. Now, there are different way of interpreting this. One might be that the agent or the dose that was given wasn't potent enough to significantly inhibit in vivo interferon signatures for patients that really had very dominant impact of interferon, and only those that had lower levels could they actually affect a biologically and potentially clinically significant inhibition. So the conclusion is that early studies with this agent have shown that you can have safety, and the question is whether there is a subset of patients that may have efficacy. Studies need to be performed with higher doses, and we'll see what evolves in the future with this agent or with others that are also targeting the same interferon isoforms. All right, so in conclusion, lupus continues to affect many individuals with a very high burden of disease and cardiovascular disease as well as venous disease. Present clinical challenges for which we are really have very limited impact, it seems, over time. So recent reports are showing progress in better clinical assessment of these patients, and we hope that in the future this will lead to better clinical decision making. There is a paper that looked at the mechanism of action of Mycophenolate Mofetil, an agent increasingly used in the treatment of lupus nephritis patients, and there's a suggestion that this may actually be preferentially targeting B lymphocytes and their activation. And this may also allow us to better understand in the future what agents to use in which individuals. And lastly, we discussed interim progress in interferon blockade trials, and there is some evidence with ronalizumab for limited efficacy, and we'll need future trials that hopefully will integrate these findings as we better understand the biology of the disease and the relevance of interferon for the development of hopefully better and more effective agents. So this is Greg Silverman, and I appreciate your attention and joining us today for our Rheumatology Highlights Report, and I hope that you'll be joining us for other programs in the near future.